For more than 20 years, Sellers Dorsey has supported transformational change in healthcare. Partnering with states, providers, health plans, and other stakeholders, we work to strengthen the critical safety net system and achieve results that improve the communities our clients serve. Our team of former federal policy officials, Medicaid directors, healthcare executives, and other professionals offer a breadth of experience, practical, and personalized knowledge to help our clients navigate the complexities of Medicaid. Today, we have a panel of Medicaid experts from Sellers Dorsey to discuss the emerging topic of aligning payers and providers to maximize the impact on quality, access, and equity within the Medicaid program. My name is Jill Hayden, a director at Sellers Dorsey, and I'll be moderating today's webinar and our esteemed panel of experts that represent the diverse work we do with various clients that operate within the Medicaid program. So let's do a round of quick introductions. Mary, I'm going to start with you.
Hi, I'm Mary Cantwell, Managing Director of the California practice here at Sellers Dorsey, and we work with a large range of clients from counties to states to hospital systems to safety net providers, as well as health plans. I've been working in Medicaid for about 20 years, first with the public hospital systems here in California, and then I spent 9 years at the California Department of Healthcare Services, which is our state Medicaid agency, first starting as the Deputy Director for Healthcare Financing, then Chief Deputy of Healthcare Programs, and then my last 5 years, I was also the State Medicaid Director.
Thanks, Mary. Karen, let's go to you next.
Sure. I'm Karen Brock. I'm a managing director within our national consulting practice here at Sellers Dorsey. I've been with the firm a little over 2 years now, and my focus is all things Medicaid managed care and the stakeholders that support managed care Medicaid programs. Prior to joining the firm, I've spent most of my career, 20 plus years, leading Medicaid managed care health plans across the country.
Thanks,
Most
Karen.
recently, I led one of the largest Medicaid health plans in Illinois, at which time the Illinois was transitioning to Medicaid managed care. And it's a pleasure to be here with you today.
Thanks, Karen. Sorry for interrupting you. Carla,
okay.
You want to go next?
Sure. Hi, I'm Carla Richardson. I'm a director working with providers on quality programs here at Sellers Dorsey. Been with the firm about 4.5 years and bring with me decades of experience with hospitals and physician practices, primarily in the areas of healthcare data analytics and value-based care. I've been in the trenches and reporting meaningful use results to CMS, collecting and auditing ACO performance measures, and helping clinics improve their workflows and addressing specific quality improvement initiatives. Most importantly, I've worked with providers to do those deep dives in the data to ensure that the work they do is reflected in the systems they use.
Thank you all so much for being here today. I'd like to start today's discussion simply acknowledging that quality has been and remains a high priority for both state and federal governments when it comes to the Medicaid program. And all stakeholders, including providers and plans and advocates, all agree that it should be. But I guess the general sense you get in the marketplace has been that providers and managed care plans have historically used separate tools and even different measurements for tracking quality outcomes. But lately, it's starting to feel more like there's a general acceptance that perhaps working in silos is not the best approach to moving the needle on quality. And we're starting to see more emerging opportunities, including specific guidance from CMS on this issue, to align payer and provider priorities to achieve better outcomes. So given Sellers Dorsey's business model working with payers, providers, and states, I'd like to open it up to the panel to comment on this. Carla, can you talk about what we've seen from CMS lately and how it's impacting providers specifically?
Sure. Through their strategic plan, CMS has clarified their priorities for programs that provide healthcare coverage to more than 150 million Americans. With an emphasis on excellence, expanded access, and the advancement of health equity, CMS is being increasingly prescriptive about the need to demonstrate positive results through their programs, including those which support the Medicaid program. Ever since the launch of Meaningful Use more than a decade ago, providers have been faced with an increased burden and frankly inconsistent requirements around quality reporting in their efforts to demonstrate the impact on delivery of quality care. And this has resulted in the need for more and better analytics, a greater focus on systems that guide clinical workflows and store medical records, and a huge demand for people who can support those systems. Recently, CMS has introduced the concept of a universal foundation, a common set of measures that are reported across programs by both payers and providers in order to increase comparability and really simplify the reporting process. This comes from a recognition of that burden that the increased reporting and inconsistent requirements is having on all the parties involved. This is really good news for providers and payers alike, though it remains to be seen on how that will get implemented. Complicating all of this is an ever-changing environment. The pandemic highlighted significant disparities in our healthcare delivery system. It also exacerbated inherent challenges in the healthcare workforce, driven by many factors, but certainly not the least of which is the aging of our population. These changes have resulted in new measurement requirements, such as screening for health-related social needs and ensuring that patients are referred to the appropriate services. All in all, greater consistency is good news for providers, and the emphasis on demonstrable results is even better news because providers have been working hard for decades to deliver the care their patients need, and these programs offer an opportunity to highlight these efforts.
Yeah, thanks, Carla. Thanks for that. Sounds like a lot of activity lately on the provider side. Karen, with that in mind, I'd like to pivot to you and just see what you've been seeing on the payer side as well.
Sure. So many of the points Carla just highlighted have impacted payers and plans as well. The good news is plans will also realize some of the same benefits that she described, although as noted, the devil's in the details. For the first time beginning in 2024, CMS will require states to report annually on a standard set of quality measures for Medicaid and CHIP enrollees. These include a core set of quality measures for children, behavioral health measures for adults, and even a set of quality measures for health homes. The intent of these requirements is to help identify gaps in health and help mitigate disparities in these vulnerable populations. So from a health plan perspective, these are all really good things. Also, this allows CMS and the states and plans to evaluate performance consistently, which is good. We all have a level playing field. As you mentioned, plans and providers have worked hard and have always prioritized quality and access. Overall, I think payers value this alignment across CMS, states, and plans, and they want to be able to continue to have the flexibility in how they get there. This is their secret sauce, and in many cases, how they differentiate themselves. They also want to be sure that they have enough time to get there and to do it right. Systems, data integration, contracting, all the things Carla mentioned, these all take time. And it will take time for providers, CMS, and states as well, Jill.
Yeah, thanks, Karen. With that in mind, Mary, I have to think that this is also impacting states, as Karen mentioned, and how they operate their Medicaid programs. Can you give us some insights on how the CMS guidance is really impacting states and some of the trends that you're seeing across the country?
Sure. And again, really consistent with what my colleagues have said, states both are wanting this type of structure, but also, have some of the same challenges that that have been mentioned. I do think that as we see more clarity from CMS, which sometimes states think is good, sometimes they don't, right? This is a partnership and it's not just a top-down approach. But as we see what CMS's goals are, it really does provide states at least with a better roadmap than they've had potentially in the past. But again, it's still allowing for that significant flexibility, which any state Medicaid director would tell you is critically important to them in their job. And, it's really going to be a challenge to have sort of that full alignment across states or even sometimes within states. I agree with Karen's perspective that trying to have sort of an apples to apples world and sort of a level playing field is important. But we also know that amongst states, across states, there are vast demographic differences and social differences in populations in the way that sort of people in a community interact. And you also have the Medicaid program where one state Medicaid program is different from another, both intentionally with the different ability to have different benefit structures, different populations. Some states cover more populations than others do, different income levels, as well as different ways of providing services, right? So you have fee-for-service systems, you have hybrid systems, you have fully managed care states. And so those are always going to affect how we can actually measure things. And so we really need that flexibility to account for that and to really make sure that the end goal of really meeting what the community needs and what those programs need are really being sort of top of mind for us moving forward. And absolutely issues with workforce are a challenge at the state level. And so flexibility is also important to really reflect the very real challenges that states have in actually trying to accomplish all of these things on top of just the day-to-day of running their Medicaid programs.
Yeah, that makes sense. And I think with that in mind, thinking about Sellers Dorsey and the way that we work, and I think, one of the things that sets us apart from some of the other consulting firms is that we really do have a primary focus on Medicaid and understanding who our clients are and what their needs are and what those flexibilities need to be. So I guess, Karen, I was just hoping maybe from the plan perspective, if you could talk a little bit about how Sellers Dorsey is working on this in terms of moving our clients forward.
Yes. So this is our sweet spot. We help our clients articulate the impact of the work that they do. We can help them tell their story, which in my opinion, and we'll talk a little bit more about later, as an industry, we've had a really tough time telling our story. Jill, as you said, we exclusively focus on all things Medicaid, so that puts us in a very unique position. We can see across the continuum of the healthcare delivery system and bridge the gap between what were silos and are now connected, or at least that's what we're attempting. We can help our clients design and implement programs at the state, provider, and plan level with creativity and flexibility, as Mary said, but also leveraging our national expertise. We work with clients all over the country. We bring best practices to our clients while showcasing their very specific value proposition, which I think is key. We always say we meet our clients where they're at. That's one of our mantras. We've been discussing the value of the core set of quality measures and alignment across CMS, states, payers, and providers with the intent that these new programs will lead to meeting equity standards and increasing access to care. Today, Sellers Dorsey is helping our clients realize the opportunity for this alignment and not just react to it. So we're actually helping them realize the opportunity. For example, we're helping payers and providers align with value-based relationships to help meet and, quite frankly, exceed these new standards. One of the things we've experienced in the 20 plus years we've been working with Medicaid programs is as changes like the ones we're discussing mature, states and plans may need to revisit specific policy decisions that they've made. We work with state Medicaid agencies, stakeholders to help address the policy impacts and that changes like this can actually create. We're providing thought leadership, program design, implementation that will solve for real business opportunities and challenges that our plans and our providers have. It may include that we bring vendors to the table, or what we call solutions providers, to help our clients prepare for these changes, such as technology solutions, which I think is something that's going to be necessary. We provide staff augmentation as our clients struggle with workforce issues. Mary and Carla both reference that. And I guess I would summarize my response by saying, as we are all moving in the same direction with the goal of improving quality, impact, and access, Sellers Dorsey can help all Medicaid stakeholders get there, which the result is better care for our nation's most vulnerable populations, which is really the ultimate goal after all.
Yeah, thanks, Karen. And I think, Carla, from this perspective, you alluded to this in some of your opening comments, but can you kind of expand on, some of the work that we're doing with providers in this space as well?
Certainly. We work with our clients, our provider clients, to design Medicaid financing programs which enable them to build on their strengths and advance the goals and objectives of their state's Medicaid program, and most importantly, support the needs of their patients. Designing these programs can be challenging because the needs of the Medicaid population is not necessarily the same as the other populations they serve. And oftentimes they're not accustomed to focusing on that population. Therefore, we may design programs which focus on specific subpopulations or clinical areas such as maternal and child health, or behavioral health and substance abuse. More recently, we've seen programs focused on stabilizing and expanding the healthcare workforce, and not just physicians, but the entire continuum of the workforce, from community health workers to nurses at all levels, advanced practice professionals, physicians, and everywhere in between. I'd say one of the most rewarding aspects of our work with providers is, and really impactful, is the coalition building that we do, and seeing the result of bringing clinical experts together to share best practices and solve specific problems. We've seen workflow sharing, collaboration on IT systems to understand the best way to get the right information out of their EMR, sharing of ideas to deliver the best care to high utilizers of emergency department services, so that maybe they're getting their care in a less costly way. It's the classic two heads are better than one approach to problem solving, and the use of formal quality improvement techniques also improves adoption and demonstrates results. So it helps them to tell their story. But it is difficult to tell the story of these efforts. Effectively communicating the work that's being done and the impact it's having on patients, that's really what we're trying to do here at Sellers-Dorsey, is help these providers tell their impact story, so that the value of these programs is clearly communicated to all stakeholders. Healthcare is traditionally so siloed. I mean, from within hospital, the healthcare systems, and in the system at large, payers, providers, government. In our programs, we've begun to see state Medicaid agencies working more closely and directly with the provider community to try to address challenges that are unique to the Medicaid population. Through the introduction of value-based contracting, there's been that, just as Karen said, that greater connection between payers and providers to row in the same direction. But really, that's the next silo that needs to be bridged. With workforce challenges, we can't afford to have duplication of efforts in the system. We have to work together to make sure that every person is providing the service that patients need clearly, efficiently, and effectively.
Yeah, thanks, Carla. And it occurs to me that Sellers really sort of has, the finger on the pulse of both the provider side and the payer side, and really understands Medicaid policy overall. And sometimes that's a struggle for states, wanting to get that story out and really having an understanding of how they're working together. And I know Sellers really helps it in that respect too. Mary, can you talk a little bit about the relationship that Sellers has with states, and sort of how we're working with projects on innovation and alignment on quality initiatives from that perspective as well?
Absolutely. Again, as I mentioned earlier, we have a lot of former, Medicaid staff who work here. And I think that really helps. From across the nation, people have come to work at Sellers-Dorsey. And so we have those relationships with those state entities. And so I think that's been really critical. And, the exciting thing is, again, having those flexibilities that we talked about earlier allows states to really be incubators for innovation. And so we've seen states do that over the past many decades. We're seeing a lot of that continuing, and CMS really being open to states proposing some new ideas and programs with that ultimate goal of improving access, quality, and outcomes. And so, our team here at Sellers-Dorsey really is well suited to support states and other entities to really be able to provide that overall strategic support and leadership, as well as the fact that we have very, skilled, in-depth technical policy and program analysis and implementation support that we can provide and have been providing to many of our clients. An example of our work here in California that was led by one of my colleagues here on the California team were two different efforts with two different state agencies here. One with the Department of Healthcare Services, which is our Medicaid agency, as I said, and the other with our Department of Managed Healthcare, which is the managed care regulator in California for almost all health plans, not all, because California likes to be confusing. So we actually also have an insurance commissioner that deals with some of the health insurance stuff, but most people's health plans are monitored by the Department of Managed Healthcare. And in both cases, Sellers-Dorsey really led the work with those agencies in developing their framework for health equity and quality measurement, helping leading stakeholder work groups to really develop what measures the state was going to use, not just in Medicaid, but across the sort of healthcare continuum. I'd also say that here in California, in the Medicaid program, we have had quality-based programs, including a lot of money tied to actual achievement as a part of our Medicaid waivers, going back to at least 2010, and really have now a significant amount of funding within our managed care system through both health plan incentives as well as directed payments for providers that are linked to the achievement of specific quality objectives. So things like some of the stuff that Carla talked about in terms of like maternal health, well child visits, all that type of stuff, diabetes management, chronic disease management. We've been doing that for quite some time, and we provide support to a variety of entities within the state in helping both develop these programs and what measures make sense for the communities and entities that are participating, as well as then helping them figure out how to achieve those required outcomes. And that really just helps support state work in trying to move the needle on quality overall in their Medicaid programs.
Yeah, thanks, Mary. It's great to hear about what's happening in California. And I know Sellers has done similar projects or different types of projects throughout the country in different states to really move the needle on quality and bring in those additional federal dollars for projects as well. And I guess I just want to address that even though all this great work has been done in the states, and we've worked on all these great projects to increase access, we know that there are still challenges, and of course there's still work to be done. So Carla, I know you addressed some of the issues previously, especially around workforce, but can you talk about some of the challenges that we're seeing specifically for providers?
Sure. As you said, I've hit on this to a certain extent. The challenges really boil down to people and data. So I'll start with data. The provider community is frequently asked to manage the care of populations where they don't really have adequate insights into all the care the patients are receiving. And while there have been huge advances made in analytics, access to data, and data consistency, not having access to timely, actionable data is the thing we hear from our clients over and over again. Impacting data needs is an inconsistency of requirements across payers and across program types that we've talked about. So one program may measure, you may have to report diabetes in control, and the next program you have to report diabetes in poor control, or a list of 10 or 12 additional diabetes measures. And this means that they have to have the systems that allow them, to do that additional reporting for the specific population. And that just adds to their burden of having to develop those systems. There's an additional need for tools that allow you to close the gaps in those measures, because all that first step is doing is the reporting. That's just telling you the what. It's not telling you it's not giving you any additional information to improve patient health. So that brings us to the next huge challenge, which of course is people. And we'll go back to data. There's a lot of conversation about the scarcity of providers in healthcare, but another level of scarcity is those technological personnel. And I think every aspect of the healthcare system is feeling that scarcity, whether it be at the state level in Medicaid programs, or at hospitals, or even at payers. Generally, hospitals don't have a real deep bench in their IT staff. And one thing we hear a lot from the folks that we work with is, well, we've got to get our request into the queue, and that queue is pretty long. And if somebody leaves out of IT, then it just kind of, the whole apple cart has been upset and puts everything back to zero. So that is a big challenge. The other one is the one we've talked about already, the healthcare workforce shortage. Luckily, we're frequently working with large teaching institutions who are working to train that next generation of healthcare professionals. And what's really exciting about not only the programs that are kind of expanding and showing some innovation and how to expand those teaching programs, but also what those providers are being taught. I was just at a conference where a group of medical students presented this gave a presentation on value-based care and how they were understanding that intersection of payment and value. And when I think about some of the providers that I worked with who weren't quite there, it's really exciting to know that that they're learning a lot more about the entire system in those teaching programs. But we know there's a real challenge in those programs to have enough preceptors to, even if you get more slots, well, what if you don't have adequate people to train the new people that you have slots for? So that's why it will continue to be important to develop programs that support medical education and really drive innovation in care delivery, so that allow payment for the full continuum of care, so that everybody possible is working at the top of their license. This will lead to innovative approaches to grow that provider community, and that's something we're seeing in the programs we support.
Yeah, that's great to hear, that the next generation is sort of thinking that way, and building that into, what they're excited about. And when we think about value-based care, Karen, I'm guessing that the health plans have their own set of challenges when it comes to these issues, and I'm guessing that some of them are also the same. So wondering if you can comment a little bit about what the health plans are experiencing as well.
Yeah, I certainly echo Carla's sentiments related to the workforce challenges. You need a workforce to be innovative, so there's sort of that double-edged sword there. Plans will have the very same issues, although slightly nuanced. When I think about some of the proposed managed care rules around network adequacy requirements, it's going to be very difficult for plans, providers, and states to meet some of these requirements, from appointment availability to addressing specialty access to the concept of secret shopper validation requirements. States and plans are really going to be challenged to get all of this monitoring and implementation rolled out due to the workforce challenges. I think all of these issues could impact a provider or plan's ability to meet some of the core measures, never mind exceed them, which is always the goal. Plans and providers have found the need to rely on technology to expand access to patient care, such as telemedicine and now telemonitoring, actually monitoring patients remotely because there's no access to providers on the ground. Another challenge I would say is around technology and the opportunities for plans and providers to find ways to align their disparate systems. And then how you effectively, and Carla touched on this, extract data and report measures in a consistent way when you've got all these disparate systems. However, I also think it's an opportunity to mitigate redundancy. Payers and providers are going to have to be creative about how they work together here. There are technology solution providers working with our clients today to help bridge some of those gaps in those systems and report on behalf of both the provider and the payer. So they take on some of that responsibility, and that is another potential opportunity. I mentioned the secret sauce earlier, and being a former managed care executive, I can tell you it's very important to plans to be able to hold on to that autonomy around what are their secret ways of being able to manage and exceed expectations. Plans still want the ability to be flexible on how they implement these programs. As Mary said, states do, plans do too. So I think this could be a challenge as the new rules roll out. And lastly, I would offer that as the PHE is ending and Medicaid enrollment is dropping, plans are seeing significant reductions in workforce. In some cases, entire departments are just gone. So long-term relationships that payers and providers have enjoyed have been completely disrupted. And this is creating challenges for all stakeholders, resulting in either implementation delays or cancellation of programs completely or altogether. But it also stifles the ability to be creative and innovative that we're all looking for. So I guess, Jill, I'll leave it there.
Yeah, thanks, Karen. I'm glad you brought up the end of the public health emergency. Mary, I'm imagining that states face some of the same challenges that have been mentioned here, by Karen and Carla. And I'm guessing that the end of the public health emergency has been especially painful when you consider the state resources and workforce as well. So besides that, just wondering if you can comment a little bit about what we're seeing in terms of challenges when it comes to the states.
Absolutely. Yeah. I mean, and again, as you said, a lot of similar things, both in terms of people, and technology. State Medicaid programs are not known for having the most up-to-date data systems. And so when Carla was talking about some of the IT struggles at providers, I remember sort of, if the one person who knew how to program this part of the system, they were getting older and they were going to retire, what were we going to do? And so, I think states, and encouraged by CMS, have been trying to, update their systems, but that is still an ongoing challenge. And a lot of that tied to the same issues for workforce for states, which is just that funding is never an easy thing to have in a state government way. You have the cyclical nature of budget deficits. And so often states then enter into freezes, if not reductions in workforce, or not allowing Medicaid agencies to hire new people. And so you have all of that, and you have then these different competing priorities, both within the state and what are the priorities there, what's coming from CMS. As you said, sort of the PHE, there's a big push that states need to be doing all of this work on the unwinding. But that then is in conflict with the same people who need to do other things. And so it just becomes, an ongoing challenge of balancing the various levels of priorities and who gets to decide. I'd also just say that states aren't particularly known either for being able to be quick or nimble in sort of changing things. And that is due to workforce challenges, but also just the nature of being state government, right? And so you have both the executive branch, but also the legislative branch, as well as, quite honestly, just stakeholders and processes that you have to go through to make any major programmatic changes or get new budgetary investments. And so, it's always going to be a challenge at the state. I don't think you would ever meet a Medicaid director in any state who would say, I have all the workforce and technology needs covered. It's not a problem. That is never the case, right? We're always asking for more. And so it just highlights the additional challenges, and then having to work with the same partners, that Carla and Karen have talked about, who are facing those same issues. It's just sort of becomes really challenging. And we do have to decide where we want to make the most both financial and personnel investment, and those priorities need to be constantly assessed.
Yeah, thank you. I think that's really insightful from the state perspective. And I think, as we think about that from the state perspective, really engaging with stakeholders is always key in the Medicaid program, whether it's payers or providers or advocates. And so I just want to touch on that a little bit more. I know we've talked about it in today's discussion, but, especially between providers and payers, thinking about that, Karen, do you mind discussing a little bit more about how managed care plans are thinking more thoughtfully about how they're partnering with providers when it comes to defining and measuring quality, and really thinking about both that CMS side, and then Mary's comments about how states are thinking about it too?
Sure. There are several things that come to mind here. I believe I mentioned earlier the alignment of payers and providers is driving what I would say to be a more serious movement towards value-based contracting arrangements. Managed care plans have always been required to have value-based arrangements in their service areas, but I think this is really a more serious movement to that. And I think it will make these types of arrangements easier to administer for all parties, which is a plus. When you think of the technology challenges we've discussed. What is the saying? A rising tide lifts all boats. I feel like that seems applicable here. Another way plans are partnering with providers is in the area of service coordination. Plans are actually delegating and paying providers to carry out specific service coordination requirements that are in their contracts with their state partners. in some cases for the type of coordination that providers were already doing. So we're eliminating redundancy. Providers are being reimbursed for those services. It's a win-win. And while I said earlier, it's kind of hard to be creative and innovative, and not to contradict myself, but where plans can be innovative and creative, we are starting to see plans utilizing like your non-traditional providers, your NEMT providers, non-emergency medical transportation providers, meal delivery providers to help close care gaps. The meal delivery person sees that enrollee every single day in their home. Why not ask them if they've had their mammography and schedule the appointment for them if they can, right? It seems like a no-brainer. One of the things that's getting a lot more attention, I think, and for very good reason, is the support for the family caregiver. In most cases, this family member is solely responsible for all aspects of the enrollee's care, getting them to their appointments, their medication adherence, their ADLs, making sure they've got their preventive care. If that caregiver isn't there, we know what happens, right? And that's how the story ends. So we are seeing plans focusing a lot more on how they support family caregivers and non-clinical caregivers, providing respite for caregivers and other resources. And then finally, I'd say one of the things that plans have been able to do is share best practices. So when they're new to a market and new to a Medicaid program, they can take what's worked in one place and try to adjust and adapt that for their new service area.
Yeah, thanks, Karen, for sort of thinking through what some of those innovations might be and really engaging those stakeholders that we don't normally think as part of the equation, especially when you think about caregivers and some of those other provider types that are already out there in the community, like you said. Carla, keeping with the provider perspective, just wondering if you could provide some insights on how providers are thinking about this as well.
So, I think the important thing in telling their story is what we've seen increasingly is getting the patient perspective in the care. You see much more use of patient family advisory councils. And this is particularly important with the Medicaid population because healthcare providers used to take a kind of, if you build it, they will come attitude toward care delivery. And now you see a much more consideration of providing care when and where the patients need it.
Karen, did you want to add something to that as well?
Yeah, I think when we think about telling the story, there probably isn't enough time today to even cover that. But I completely agree with Carla's comments. I think I would add that the way we talk about quality and measures has been about how we report quality, which is a retrospective view. It's not prospective. We don't talk enough about the initiatives or programs that we are undertaking prospectively to achieve the results that we've been talking about in the form of metrics. Examples, that healthcare vans that are deployed to tent cities to find pregnant moms to engage them in care. The funding of behavioral health clinics inside a health center to facilitate the integration of physical and behavioral medicine. Health plan care coordinators that evacuate nursing homes during wildfire season. These are just a few of tiny examples of my personal experience of the good work that payers and providers have been doing for years. But as I said, there's not enough time to cover all this. I think we do need to do a better job of telling the story for sure.
Yeah, thanks for that. And I think, Mary, I think we've actually, Sellers has done some work in California, specifically around payers and providers. I was wondering if you could speak to the project that we worked with UC Health System on specifically to illustrate, some of that work that we've done.
Sure, yeah. As you said, we do this all over the country with a variety of entities, but the University of California Health System is a relationship that the Sellers Dorsey firm has had for many years, since prior to my coming. And just as background for those who aren't familiar, that the UC Health System, encompasses, obviously teaching hospitals in several counties here in California, as well as, physician practice groups and sort of the whole spectrum of healthcare services, and is a really significant provider of services in the Medi-Cal program here. Particularly, they serve a unique role in serving for particular specialty care services, quaternary, tertiary care that isn't available sort of broadly across the state. They have seen a significant increase in their Medi-Cal utilization, nearly a third increase in their inpatient utilization, that is Medi-Cal, as well as ongoing complex outpatient services that are needed for this population. One of the really great things in our work that we've been able to do with the UC systems is really help them have stronger relationships with managed care plans, particularly over the last 5 to 10 years. California being as complicated as it is, our Medicaid program has 24 health plans that contract to provide services to our 14 million people. It's because of a county-based structure. And so the UCs now have contracts with 23 out of the 24 health plans, which was not the case, 10 years ago at all. And that has been improving a lot. And a lot of that is also linked to the work that we've been doing with them. Again, because of their role in specialty care and sort of that, those unique services, they don't just contract, like UCLA doesn't just contract with the plans in Los Angeles, right? They have a wide footprint and people travel from far and wide across the state to go to these centers for these types of services. And, in our work with the UCs, they've been partnering with the other public hospital systems and the state and the health plans to implement new directed payment programs that came about after the 2016 managed care rule that really focused on sort of what were the network requirements, how did these systems need to contract with health plans, and it's been very helpful in being able to, again, grow that relationship with plans when you have this additional money to support the services, because the reality is, they have to be financially viable in order to continue to be there, not just for the Medicaid population, but for all Californians that are going to need their services. So two of those programs, the enhanced payment program is essentially a increased payment adjustment on top of sort of the base payments that managed care plans pay for those in-network services that are under the contract. And then sort of sticking with the theme that we've been talking about today in terms of value-based payment, we also have the quality incentive program. And that is really payments tied to particular and increasingly harder outcomes on the types of measures like the adult core set or the child core set, and particular health equity measures that we've developed here. And between those two programs, really the money is split about 50-50. So California has really put an emphasis on that. And the University of California systems are doing quite well under the quality incentive program and are very proud of the quality services that they're providing to those in the Medicaid program. Sellers Dorsey also assisted in implementing a graduate medical education funding for Medicaid managed care beneficiary costs that really serves the purpose of what we talked earlier of supporting GME and the training of physicians, but also dentists and other providers as well. We also worked with the University of California last year into this year for development of a particular directed payment program tied to transplant services that were newly carved into managed care that historically had been paid outside of the managed care system. And so that was really critical. There's not very many of them, but they are costly and challenging things, and really ensuring for both plans and the hospital systems that the reimbursement would be sufficient in order to maintain access to those services. As part of our overall work with UC, we also just provide, strategic help with them thinking about their relationships with plans, but also with states and other providers as needed. And one of the key things, again, sort of harkening back to earlier parts of this conversation, is we're actually really doing a really in-depth dive into their data to help us and them better understand who their Medi-Cal population is, so that we can figure out future initiatives that would further improve access and outcomes for those beneficiaries. So it's really exciting work. Again, it's been a long-standing relationship, and I've been very encouraged to see the growing role of UC in the Medi-Cal program.
Yeah, it's a great example of everything that we've talked about today in terms of highlighting how important it is to create those relationships between the provider, between the payers, between the state, all coming together with, common goals to really achieve those outcomes that the feds are looking for as well. And really how innovations and flexibilities can be used to improve access and quality and equity. So thank you so much for that. I just want to piggyback off of Mary's discussion of that project. And I know we've talked about challenges, but I want to open it up to the panel also to talk about some opportunities that might lay ahead, or sort of what you're anticipating when it comes to these alignment initiatives in the future. And Carla, I'm going to start with you, if that's okay.
Great. Yeah, I think some real opportunities are when we start to tell the story that's beyond just the measure, beyond that 89% adherence, digging deeper to tell that underlying story behind the good results, lives saved through early cancer identification, increased patient engagement stemming from a more stable and diverse workforce. And those avoided higher costs from those preventive services that are being offered. One of the biggest opportunities as we break down the silos that we're talking about is that ultimate partnership, the one I just mentioned, the one we have with patients. So the next big phase will be incorporating that patient voice into the innovations and really understanding the challenges patients face in getting that right care at the right time at the right place.
Yeah, that's a really good point, and definitely illustrates that need for equity and including the patient and having a voice in the conversation as well. Karen, I'm going to pivot to you.
Yeah, and I would just piggyback on that, Carla, and say that, we're talking about the whole person. So I continue to be very optimistic about the focus on the integration of physical and behavioral health care. We've got an unprecedented mental health and substance use crisis going on in our country right now and in our world. And to have all stakeholders focused on the integration is, in my opinion, the right direction to approach.
Yeah, thanks, Karen. Mary, any further comments on this one?
Sure. Having to go last when people already say all the good stuff. No, I'm just kidding.
Sorry about that.
I think along the same lines and really building off this concept of the whole person, because I do think that has really one of the biggest changes I think we have seen over the past, several years is the recognition of the need for integration, the need for hearing the patient voice, but also all those parts of a person's health that are affected by things outside of what is technically considered healthcare. And so really having looking at those factors and Medicaid being willing to be a partner in this, looking at stuff such as, food insecurity, housing challenges, environmental issues, all of that is so critical that I think there's a lot we're seeing now. And I think we'll continue to see into the future opportunities about how Medicaid entities can work with stakeholders across that whole continuum that really define what someone's health and well-being are going to be.
Yeah, that's a good point. And I think we've focused a lot on sort of the CMS guidance that's coming out around quality and standardizing things and aligning things. But one of the things we didn't mention is recent guidance from CMS around health-related social needs and really acknowledging a lot of the things that you just mentioned, that there is more to a person than your traditional healthcare services that need to be considered as well. And so that sort of brings us back. It's, I think it's important to remember that Medicaid truly is a partnership between the states and the federal government. And based on today's discussion, it feels like, that CMS guidance is helping move the conversations between states, payers, and providers by streamlining and standardizing some things, but also remains flexible enough to allow states to determine their own needs and goals for their communities when it comes to quality access and equity. So as we wrap up today's discussion, I just want to give you all an opportunity to summarize why this movement is so important and what we should be thinking about as we work to implement these initiatives with our clients. And Karen, I'm going to let you go first.
Great. This has been a great opportunity. Thank you so much. How we achieve this alignment is going to be very dependent on how we work together, as we talked about breaking down those silos. But it's also dependent on how we achieve alignment in Apache County, Arizona is going to be very different than how we do it in metropolitan California. Sellers Dorsey can help all of our stakeholders work out what they can do with the flexibility and creativity that we all are desiring, where we can come in and help our clients build on their strengths, their value propositions, leverage what they can bring, including brokering relationships and partnerships across payers and providers, and what we hope to achieve in accelerating what our clients can achieve. We've got a summary of the proposed rule. We've published the summary of the proposed rule and comments that CMS has received on that rule that can help explain other stakeholder concerns. And I'd encourage our audience to review that.
Thanks, Karen. Carla?
Well, Karen is exactly right. There is not a one-size-fits-all solution. And more importantly, no single player in the system can achieve the desired results alone. Stakeholders need to collaborate and innovate, and there needs to be the room to allow those innovations to take hold.
Yeah, thanks, Carla. Mary, last but certainly not least by any means. We'll let you wrap it up today.
Sure. I mean, I think, obviously everything that Karen and Carla said are, I agree with. The one additional thing that I would add is that, we are often working with sort of core safety net Medicaid providers. And so part of what we can do is help figure out that balance between the focus on achievement of these goals or these particular measures, which as mission-driven organizations, and I think has been mentioned, they really believe in and want to do. But how do you do that in a world where their financial viability is sometimes a day-to-day question, not just a year-to-year question? I'm having that with a client right now where, we're very concerned about their ability to continue to operate in the community. And, that's because these systems really serve huge numbers of Medicaid and uninsured populations, much more than other systems do. And so we need to look at how we make sure the financing structures are also created in a way that can assist these providers in achieving the state's goals and CMS's goals. And I think we are seeing that across the board in the work that we're doing with a lot of these safety net entities. And Carla talked about this earlier on, which is structuring these value-based arrangements, the QIP program here in California, that is about both, right? Increasing that reimbursement, but linking it to these goals and making sure that it's achievable and realistic.
Yeah, absolutely. I think that's a really great note to end on and does a great job of summarizing, what we've discussed today from all perspectives. So I'd really like to thank all of you for participating today. I think we did a great job of sort of illustrating the work that we've done, the work that still needs to be done, and how we can really move this program forward. I also want to thank Becker's for giving us this opportunity to discuss such an important topic. You can find out more about Sellers-Dorsey and our work in the Medicaid program on our website, sellersdorsey.com, including our newsletter, policy analyses, including those proposed rules that Karen mentioned, and bios and contact information for the team members on today's panel. Feel free to reach out to any of us with questions or requests for additional information. We'd love to work with you. Thank you for joining and enjoy the rest of your day. Thanks.
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 Thank you.